Welcome to Deep Dive Ortho, the show dedicated to really digging into orthopedic knowledge. Today, we're taking a closer look at a condition, well, one that often affects athletes, particularly those involved in throwing or racket sports. Flexor Pronator strain of the elbow. You might think it's straightforward, but actually there's quite a bit of complexity we're hoping to unravel today. And guiding us through this intricate topic is Professor Mo Imam, a real expert in the field. Our mission really is to unpack Flexor Pronator strain anatomy, presentation, diagnostics, right through to rehab nuances. We want to get beyond the basics. So, Professor, let's start there with the fundamentals. For our listeners, many are already familiar with the term. What truly defines a flexor pronator strain in your clinical experience? And who are the main groups we should be thinking about?
That's a great question to start with. Beyond the textbook definition of an acute or chronic strain just distal to the medial epicondyle, what often stands out is that specific pain location combined with the mechanism. So either it's that single large eccentric force, the golfer hitting the turf hard, or it's the chronic repetitive stress. We see it a lot in golfers, cricket players, baseball pitchers, javelin throwers. And critically, particularly in throwing athletes, you absolutely have to rule out associated ulnar collateral ligament insufficiency. That's paramount.
Okay, let's unpack that a bit. Understanding the anatomy feels crucial here. Could you walk us through the key muscles involved and specifically why they're so vital for medial elbow stability?
Certainly. So the flexor pronator mass, it acts as this dynamic support against valgus stress, that outward bending force on the elbow. It's made up of 5 muscles, sort of layered proximal to distal. You got the pronator teres, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis, the FDS. Those first 4 are mostly median nerve innervated. And then number 5, the flexor carpi ulnaris, or FCU, innervated by the ulnar nerve. Now, what's fascinating and really quite important biomechanically is that the FCU and the FDS, because of their position right over or very near the MCL and their relative bulk, they are incredibly well suited to provide that dynamic medial support. This is especially relevant for, say, overhand throwers who experience those extreme valgus forces during throwing. And remember, the ulnar nerve runs right between the 2 heads of the FCU, making it a prime spot for potential compression or irritation.
Right, that anatomical picture really sets the scene for potential problems. So let's translate that. A patient walks in, perhaps a pitcher or a tennis player, complaining of medial elbow pain. What's your thought process? What are those key historical details, the symptoms, the specific physical exam findings that make you think, okay, this is likely a flexor pronator strain rather than, say, medial epicondylitis or a primary UCL issue?
It really starts with listening carefully to the history. Was there an acute event? Or is it more of an insidious onset linked to their sport, that repetitive gripping and valgus stress? The pain is typically described as being on the medial side, but usually a bit distal to the bony prominence of the medial epicondyle. Throwers might pinpoint it to the late cocking or early acceleration phase. On examination, with acute strains, you might actually see some swelling, maybe even some bruising medially. Tenderness to palpation is usually quite specific, just distal to the epicondyle. Then you move to provocative tests. Pain with passive elbow extension, and crucially, pain with resisted wrist flexion or resisted forearm pronation. These are quite indicative. A thorough neurovascular exam is essential, of course. And here's a really important point. The moving valgus stress test, which we often associate with UCL tears, might actually be negative in isolated flexor pronator strains.
That's a critical distinction, isn't it? That a negative moving valgus doesn't rule this out.
Exactly. It helps differentiate, although sometimes, sadly, both can coexist.
Okay, so examination gives us strong clues. When do you decide to bring in imaging? What questions are you trying to answer with, say, an X-ray, an MRI, or perhaps ultrasound?
Well, radiographs are usually the first step, mainly to rule out any bony injury, avulsion fractures, that sort of thing. They're often normal in a pure flexor pronator strain. MRI becomes really useful when the diagnosis isn't clear-cut, or if you suspect a more significant injury like a high-grade tear, or if you need to definitively rule out other pathologies like a UCL rupture. On the MRI, you're looking for specific signs of edema, so fluid signal within the flexor pronator muscle bellies or tendons, or perhaps clear evidence of partial or even complete tearing. Ultrasound is another option, and it can be very effective, particularly as it's a dynamic and often more cost-effective. You can see hypoechoic areas suggesting tendon degeneration or tears. The main caveat with ultrasound, though, is that its accuracy is very much dependent on the skill of the operator. And throughout this process, differential diagnoses like medial epicondylitis, UCL injury, and valgus extension overload are always in the back of your mind.
Right, so we have a clear picture of diagnosis. Let's move on to management. What's the standard non-operative pathway? And importantly, what are the common pitfalls to avoid during rehabilitation? Plus, how do we best advise patients on prevention?
The good news is that treatment is generally non-operative, and that's the first line. It usually involves a period of rest from the aggravating activity, NSIs for pain and inflammation, and activity modification. Physiotherapy is absolutely central. The focus initially is on restoring pain-free range of motion, followed by progressive strengthening of the flexor pronator muscles. This typically takes around 4 to 6 weeks. Corticosteroid injections are, well, rarely indicated for chronic tendonitis here, and you have to be extremely cautious. You definitely want to avoid inadvertently injecting near the UCL due to the risk of weakening it. Surgery is reserved for quite specific cases, usually significant tears with retraction of the muscle, generally more than about 2.5 centimeters. But for most, the prognosis with non-operative care is good, with return to sport often within that 4 to 6 week window of restriction, followed by gradual reloading.
And prevention. What are the key takeaways for athletes?
Prevention is multifaceted, really. It starts with proper warm-up routines, light aerobic work, dynamic stretches for the wrist, forearm, elbow. Then, targeted strengthening exercises are key. Wrist curls, pronation supination work, especially eccentric exercises to build tissue resilience. Technique is also vital. Ensuring proper form in their sport, using the right equipment, think grip size on a racket, for example. And then there's load management. Gradual progression of training intensity and duration, allowing for rest and recovery, and crucially, teaching athletes to listen to their bodies and back off if they feel excessive fatigue or pain.
That's really comprehensive advice. Now, this is where things get particularly interesting, moving beyond the standard picture. Recent research, especially using ultrasound, seems to be revealing a much more complex relationship between the flexor pronator muscles, the ulnar nerve, and medial elbow pain, particularly in throwing athletes. Could you elaborate on these newer findings?
Absolutely. This is an area where our understanding is definitely evolving, and it's quite fascinating. Some recent studies, particularly using high-resolution ultrasound, have shed significant light on this interplay. One study I found particularly insightful examined male baseball players who had medial elbow pain. They divided them based on when the pain occurred during pitching, either at the point of maximum external rotation, let's call it ER, or during ball release, BR. Now, what they found was quite striking. The players who experienced pain during MIR showed significant atrophy, meaning a reduction in size, of their flexor carpi ulnaris muscle, the FCU, when measured at rest, compared to healthy controls.
Atrophy of the FCU specifically in the MER pain group. That's specific.
Exactly. At the same time, the ulnar nerve itself showed significant swelling, measured by its cross-sectional area, in both the MER and the BR pain groups. However, the swelling was notably more pronounced in that MEA group. So this suggests a strong association. Athletes with medial elbow pain during maximum external rotation often have concurrent ulnar nerve swelling.
Okay, so FCU atrophy and ulnar nerve swelling, particularly linked to MER pain. How do these findings connect?
Well, the study also found a negative correlation between the resting size of the FCU muscle and the cross-sectional area of the ulnar nerve. In simple terms, as the ulnar nerve gets bigger or swells, the FCU muscle, which it innervates, tends to get smaller. It atrophies. This raises a really fundamental question. Could the ulnar nerve pathology, the neuropathy, actually be causing or at least contributing significantly to the FCU atrophy? It flips the perspective slightly, doesn't it?
It really does, rather than just seeing them as two separate issues occurring together.
Precisely. And diagnostically, this research offered something quite powerful. The ulnar nerve cross-sectional area ratio. They calculated this by comparing the nerve size in the throwing arm to the non-throwing arm. A CSA ratio greater than 127% demonstrated remarkable diagnostic accuracy, 100% sensitivity, and 88% specificity for detecting medial elbow pain that was accompanied by this ulnar neuropathy. That gives us a potentially very useful quantitative measure.
Wow, that's quite a diagnostic marker.
It is. And it makes sense biomechanically, too. The valgus stress during error inherently puts significant mechanical stress on the ulnar nerve. We know that elbow flexion beyond about 120 degrees can stretch the ulnar nerve near its elastic limit. So pain during error might be strongly linked to this nerve stress and its consequences, like the swelling and potentially the FCU atrophy. Pain occurring later, at ball release, might be more related to the eccentric contraction of the flexor pronator muscles themselves, perhaps more often with a coexisting UCL injury.
So this research really emphasizes looking beyond just the UCL, even though UCL issues are common, sometimes even in asymptomatic athletes.
Exactly. While UCL integrity is, of course, very important, these findings highlight that evaluating the flexor pronator muscles and, critically, the ulnar nerve provides a much more complete picture for diagnosing and managing medial elbow pain. It explains why some treatments focusing only on the UCL might fail if there's underlying nerve pathology or significant muscle dysfunction.
That's a paradigm shift, really. So, taking these sophisticated insights on board the muscle atrophy linked to nerve swelling, how should this knowledge refine our approach to rehabilitation? And what are the absolute don'ts we need to avoid?
It certainly adds another layer to consider in rehab. The overall prognosis remains generally good, often return to sport within 3-4 months with good management. But rehab is where we translate these insights. The common pitfalls become even more critical to avoid in light of this nerve involvement potential. Firstly, inadequate warm-up is still a major issue. You need to prepare the tissues dynamically. Secondly, progressing exercises too quickly. If there's potential nerve sensitivity or muscle atrophy, you absolutely cannot rush strength training. Start gently, focus on pain-free movement, and progress very gradually. Thirdly, ignoring pain signals. Athletes, especially high-level ones, often want to push through pain. But if significant pain occurs, particularly pain with neural characteristics, you must modify or regress the exercises. Pushing through is counterproductive.
That makes perfect sense. What else?
Fourthly, neglecting recovery. Sleep, nutrition, rest days. These are fundamental for tissue repair, both muscle and potentially nerve healing. Underestimating recovery is a frequent mistake. And finally, something often overlooked is mental readiness. Rehab can be long and frustrating. Setting clear, realistic goals, monitoring the athlete's psychological response, and ensuring they feel confident is crucial for adherence and ultimately a successful return to their sport. Addressing fear of re-injury is key.
What an incredibly insightful discussion on Flexor Pronator strain. We've certainly covered a lot of ground today, from the core anatomy and clinical signs through to this really cutting-edge research connecting muscle changes, nerve swelling, and specific phases of throwing. It's clear there's more to it than meets the eye.
Indeed. I think the key takeaway, perhaps, is appreciating this complex interplay between the flexor pronator muscles and the ulnar nerve, especially in our throwing athletes. It really does challenge us, doesn't it, to broaden our assessment beyond just thinking UCL and consider these dynamic muscular and neurological factors.
Absolutely. And that raises a crucial question for you, our listener. Considering this interconnectedness, we've discussed the potential for muscle atrophy linked with nerve swelling. What subtle changes might you consider implementing in your own diagnostic workup or your rehabilitation strategies for medial elbow pain, particularly when managing throwing athletes? How might this refine your clinical approach? If you found this deep dive valuable, please do take just a moment to rate and share Deep Dive Ortho with a colleague. We really do appreciate your support. Until next time, keep exploring and keep diving deep into the fascinating world of orthopedic insights.